talking with Shaun from the Melbourne University. He's doing some work with Indigenous workforce development, so it's great to have you here at conference, and we're really looking to hearing your presentation tomorrow. So what are the key issues you're seeing for Indigenous workforce at the moment?
Capacity in terms of numbers. So with a much smaller population in Australia, about 3% of the population, to develop the workforce and to get students into medicine or any of the health professions and to support them through that program is fantastic, and we've reached population parity in recruitment. We haven't reached population parity yet in graduation, so some students are taking longer to get through or changing their decisions when they're in medicine. But things are looking good in terms of developing the workforce, but we're always going to be hamstrung by a small population and the demands on that population. So we have 20 or thereabouts medical schools in Australia. All of them are required to do Indigenous health teaching and learning for their students. That means we need all of those medical schools to have the right number of Aboriginal people to deliver the content, and that's always, I think, going to be a challenge.
Today on the panel you were talking a little bit about implicit bias and the impact that that's having on the medical workforce. Could you share some thoughts about that?
Sure. I'm going to talk a bit more about it tomorrow, but in terms of developing curriculum, I think Aboriginal people have always been represented in a deficit model. That is, the Aboriginal representation in curriculum has probably been a 40-year-old male with diabetes, heart disease, probably a low-paying job and probably a poor education. That simply doesn't represent the diversity of Aboriginal experience. And what it does do, when that's the only representation in the curriculum, is that the medical students, most of who are not Aboriginal, think that that's what most Aboriginal people are like. They're rarely taught by an Aboriginal doctor, they rarely have clinical placements in Aboriginal contexts, and so they leave medical school with the picture of Aboriginality and Aboriginal people as sick, poor, poorly educated. So that feeds into their implicit bias or their unconscious bias about when they do see a patient, what are their expectations, and it affects the way that they make their decisions.
You also talked earlier about having disruptors, like, how do we change the narrative to be more strengths-based? Have you got any thoughts about kind of what's required for that to occur?
More and different representations. So instead of having the Aboriginal person always as the patient, you could actually represent the Aboriginal person as the doctor. I think there's a lot of work to be done in employment, so that if your faculty has more Indigenous people in it, the implicit and unconscious bias of students and of staff is challenged because they actually have an Aboriginal person for whom they have to work with. And so all of those stereotypes that they've grown up with and are represented also in the media are challenged by the fact that they actually work with someone who isn't like that. We have a growing Aboriginal professoriate, which is not as advanced in numbers as it is over here for Māori, but we are certainly learning from what you're doing over here in that, and I'm talking about particularly in health. And so as those people kind of take their positions of leadership and influence the academy, the unconscious and implicit bias is challenged. The other thing I think you can do is actually to have strengths-based cases in your curriculum, so that the Aboriginal person isn't always just the sick person with a burden of disease. He or she may be the driver of a motor vehicle that's in a car accident, so they can be represented as different kinds of learning opportunities for the students that aren't always based around chronic disease, which leads to a kind of lifestyle choices as the students understand it, and that deficit model.
You talked a little bit as well about place-based kind of care. Tell us some more about that.
There's discussion around what people mean by pan-Aboriginality or pan-Indigenous. I'm involved in a research project with people at Auckland University and Otago, and Melbourne and Western Australia, and a couple of universities in Canada. And we've struggled with this notion of a shared experience. And whilst there are some shared principles across those three countries, for example, your approaches at a local level need to be different. And so what that means is you have to respect the local experience. So you can talk about the values that underpin your medical education, you can talk about the values that should be a part of doctor-patient consultation around empathy and around communication skills and decision-making and ethics. But that actually needs to be applied in a place-based way, so that your teaching is engaged with the community of where you are. I think medical schools still have a social contract, and I think they still are and should be engaged with their local communities in terms of a service role. And that actually means what it says, local communities. So Auckland, for example, has a relationship with its communities in the geographical region and its footprint region. Melbourne should have a relationship with the communities in and around the city of Melbourne and our identified other partner places. But it means that you're responsive to the people that you're there to serve, as opposed to just a philosophy of this is how you engage with Aboriginal and or Māori.
We also talked a little bit earlier about narratives, about Indigenous narratives as part of the healthcare system and the healthcare conversation. And have you got any further thoughts about that?
As I said before, the narrative is strongly deficit-based, which is also fed by the media in many ways. But I think that's starting to change as more Aboriginal people become in positions of leadership and influence in universities and medical schools and healthcare systems. In Australia, there's a growing number of Aboriginal doctors, there's a growing number of Aboriginal academics, and the narrative changes because they're there. So you don't talk about Aboriginal people in their absence. You actually talk with them because they're in the room or they're in the meeting. There was a report put out in Australia only late last week which showed that Australia still is led mostly by white males in terms of the positions of leadership and influence. None of the Vice-Chancellors in Australia are Aboriginal yet, although we have a range of Deputy Vice-Chancellors. So I think as people take positions of leadership and influence, the narrative changes because you don't talk about them as if they're not there. I think there's a parallel with, in a post-feminist sense, women taking positions of leadership as they should, and women not being talked about in their absence. But it's a relational discussion, often led by women. But you look in a historical sense, that wasn't always the case.
So you've seen a difference? Like, is it having an impact?
Definitely. We're hosting a dinner at Melbourne in a few weeks' time, and we'll have 10 or 15 Aboriginal professors in the room. On a gendered sense, more than half women. Our keynote speaker is one of your Māori professors here, Linda Smith from Waikato. But in terms of excellence and leadership, it'll be a fantastic celebration of Indigenous scholarship, and it would only be 10 or 15 years ago that simply wouldn't have been possible. A, because there weren't that many Aboriginal professors in Australia, but B, gathering them all together in the one place is unusual. So am I seeing a difference? Absolutely, and I think things are changing positively and probably quicker than we imagine sometimes.
That's fantastic. Well, it's been great to have you here with us today. I hope you've enjoyed the conference and
fantastic.
The amazing Auckland weather, and we'll be looking forward to seeing where you get with the work that you're doing.
Thanks
again.